hello. Welcome. Welcome for our special guest today is Owen Foster. The Green Mountain Care Board is an independent 5-member board established by the Vermont legislature. The board is charged with improving the health of Vermonters while controlling health care costs, increasing access to high-quality care, and ensuring greater transparency and accountability in the state's health system. Owen Foster served as an assistant U.S. attorney for the District of Vermont for 8 years, where he was the healthcare fraud coordinator and ethics officer. Prior to joining the U.S. Attorney's Office, he was a securities litigation associate for 7 years at, Deckert?
You got it.
LLP. Owen was born and raised in Middlebury, Vermont, and graduated from the University of Vermont in 2001, from Columbia Law School in 2007. Owen was appointed by Governor Phil Scott in 2022. His term ends in September 2030. Please welcome Owen Foster.
Thank you. Is my mic working okay? All right. Well, thank you, David and Linda, for having me, and Travis for setting me up. I'm really excited to speak with you all today. I believe healthcare is one of our most urgent issues that we deal with as a state. I'll give you a brief background on myself and the board, and then I'll launch into some of the information that I brought for you today to discuss. So as David said, I'm an attorney by training. As a federal prosecutor, I defended doctors and FQHCs in medical malpractice cases, and I did a lot of healthcare fraud cases, mostly against pharmaceutical companies, electronic medical record companies, and others. Also some drugs and gun cases here and there. So kind of a wide variety of work in that sphere. And then in 2022, Governor Scott appointed me to chair the Green Mountain Care Board. The Green Mountain Care Board is set up to be independent and apolitical. So what that means is the governor chooses the members. We have 5 members, and for any action to happen, 3 people have to agree. It's a quasi-judicial function, and what that means is they're essentially court cases that come before us. So a regulated entity will come with information that they need to give to us, and the 5 of us will ask questions, gather evidence, and have hearings on the information. Then we'll deliberate in public, and we'll vote, and then we make a decision on however the 3 people decide to go. From there, there's a process where the regulated entities can appeal, and they can go to the Supreme Court and say, hey, the regulator, the care board got it wrong. Supreme Court decided differently. And from time to time, we are appealed, and that's what we do. There is some misconceptions as to the scope of what we do. We do not do a lot of things in healthcare in Vermont. Like, there's actually kind of a limited, narrow view of what we actually do. So I'll give you some examples. Hospital budgets. That is one of the most important things that we do at the Green Mountain Care Board. And in that role, a hospital comes to us and says, here's how much money we would like to have in our budget for this year. And it's comprised of this much money from Medicare, that covers seniors, this much for Medicaid, and then this much for commercial lives. And then the second thing they ask is, how much more money can we have from the commercial payers? And generally, you'll say, okay, we're not making enough money to cover our expenses on these other government payers. Can we have more from the insurance people? And we'll make decisions on that. The other big realm of our decisions are what's called the qualified health plans. The qualified health plans are about 70,000 lives in Vermont. They're the Affordable Care Act plans. They cover individuals and small group employees with less than 100 employees. There is a huge swath, about 300,000 commercial lives in the state of Vermont. We regulate 70,000 of them. I think the conception is like that we do all this other stuff on insurance companies and insurance rates. We have nothing to do with it. Nothing. It doesn't come before us. We don't look at it. We know nothing about it. I mean, we know about it, but it's not part of our purview. Medicare Advantage. We have nothing to do with it. We don't regulate it. We don't decide rates. We don't decide if they can be here. We also regulate ACOs. Those are accountable care organizations. There's only going to be some Medicare ones. That landscape has changed quite a bit. So we don't regulate the FQHCs, the federally qualified health centers. So you have community health centers here in Burlington. We have nothing to do with their budget, nothing to do with their decisions. There are what's called ERISA plans in the commercial insurance market, nothing to do with those. There are independent providers, so like Green Mountain Surgery Center. Those don't come before us unless it's a certificate of need, which is a different realm. Your independent primary care practices, we don't regulate those. Mental health, Howard Center, none of that is before the Green Mountain Care Board. I think we tend to be more present in the media, I think because we have a very open and transparent process. So sometimes I think people think we have a lot more authority over the health system than we do. We're also not the lead on policy in the state of Vermont for healthcare. That's the governor, that's the legislature, and that's the Agency of Human Services. So we don't decide the major policy directives of the state. Sometimes we will have a vote depending on the particular thing that's before us, but generally speaking, policy decisions on healthcare have been given to the governor and the administration. So when I speak at these things, people often say, well, why aren't we doing single payer? And I say, go speak to the governor and the legislators, because we can't do that on our own. And people often think that we dictate Medicare rates. Well, Medicare's not paying enough, cover them. We have nothing to do with what Medicare does, that's feds. People complain about what Medicaid pays, or maybe Medicaid charges too much. Again, that's AHS, nothing to do with us either. So I just want to give the scope of what we can and cannot do, and that's not to minimize the importance of our role. Our role is very, very important in the health system. My goal for the Care Board is to also be something of a transparent data organization. So we do a lot of work to get information about all those other swaths of healthcare that we don't regulate and don't have authority for. I think that having the structure we do, where there's different pieces regulated by different people, you get siloed and you make decisions based on your silo, but not the whole system. And that's part of the problem I think we've had here in the state of Vermont. People aren't looking at the whole picture when they're making decisions. So that's been a big focus of mine. Another has been the affordability of healthcare. As we'll get into, Vermont has arguably the highest insurance rates in the country, and on the QHP plans, they are the highest in the country. So I want to talk about that a little bit. And then I also want to talk about an issue that's very important to seniors, which is this issue called Medicare cost sharing. I presume many people here are Medicare patients, and they're covered by Medicare. And when you go to the doctor, you have a copay. It's typically 20%, right? And so you go to your primary care doctor, it's $100 for the charge, Medicare pays $100, you pay $80. And I'll get into the details of this. It's a little confusing, but I'll try and keep it simplified. If you go to some hospitals, critical access hospitals, those are smaller hospitals in our rural communities, and they're very important to access in those communities, you'd pay a different amount than if you went to, say, UVM here in Burlington. UVM is a large academic medical center. It's not a critical access hospital. And what happens is, if you go to the small hospital, you pay 20% of the list price. If you go to UVM, you pay 20% of the amount that's actually paid. And so the list price can be a multiple of what's actually paid. It's like buying a car. You go to buy a car and it'll be $60,000, but you can really pay like $45,000. So if you go to a small critical access hospital, you pay 20% of a very inflated amount. So if you go to the exact same procedure, but at UVM or Rutland or a different hospital, you'd pay a much smaller amount of money. And this is an issue that's that's kind of been brought up, and that I think needs a solution very quickly, because a lot of people in our rural communities, our seniors, are paying exorbitant amounts. If they were to pay less, Medicare would actually pay more. That's the distinction. So I'll get into that because it's a matter that is really important to me. Kind of setting the stage, it is true that our healthcare system is incredibly, incredibly strained. And if you sit in my role, you live this, because you have the hospital budget process, and the hospitals have financial problems. They're not doing great financially. A number of them are in really serious financial predicaments. Some are doing okay, some are doing well, and a number of them are doing really, really poorly. And so what's the solution to that? The only real solution the board has, where I work, is to give the hospital more money, which would come out of the ratepayers in the commercial market. That's about all we can do to help with the solvency of a hospital, is to charge Vermonters more money. So you do the hospital part, and they don't have enough money, and they need money from the commercially insured patients here in Vermont. Then you do the insurance part, and guess what? The insurance company here is nearly broke too. And the people who are paying the insurance company pay the highest amounts in the country. So I can't give the hospital more money without having a lot more problems for the people at the insurance company who are going broke, or the people paying the insurance company. Then you go and meet with the independents, the FQHCs, the primary care doctors, the mental health agencies who we don't regulate, and they're all broke too. So there's really not a very easy and obvious solution here, and this has been something that's percolating for quite a long time. And I want to call out the history of this. And it's something that I've seen kind of across sectors in my life, which is it's really hard to solve problems. And it's something we should all think about. Why can't we solve these things? Like, why? We all know healthcare is a real problem. We all know housing is a real problem. We all know the education system is a real problem. And they've been a problem for a decade, yet we can't solve them. I'm actually going to be hosting a podcast next month. It's great. It's called No A and Creamy. If you guys ever listen to it, it's a really interesting podcast. The hosts do a great job. I'm going to be a guest host. And this is a topic I want to explore, which is why in Vermont are these problems so stubborn and difficult for us to fix? So this is a letter from Governor Scott on June 1st, 2022, signing into law a bill called Act 167. So that's nearly 4 years ago. 4 years ago, Governor Scott signed a bill to address the urgent crisis we have in healthcare. And in signing that bill, he wrote, quote, "Stabilizing our healthcare system has become increasingly urgent. Our healthcare system's ability to provide access to affordable, timely, and quality care is currently very fragile as it emerges from the pandemic and confronts the impacts of deferred care, an aging population, a workforce crisis, and the historically high inflation that increases the cost of supplies, energy, and staff. With all these factors, the system is at risk of significant disruption and instability." In conclusion, I want to underscore the sense of urgency I feel. And he was exactly right. 4 years ago, we were in an urgent crisis to deal with healthcare. Sitting here today, my day-to-day life is working in the healthcare system. There have not been any significant changes to have a long-term solution for any of this 4 years later. And I guess I'd challenge all of us and say, where are we going to be in 4 years from now? I think you said my term ended in 2030, which feels like forever. But what am I going to be saying in 2030 when I come to this room? Are we actually going to have made these changes? And I think when we want to look at solving problems, we need to actually say, where do we want to be in 4 years? And what are we going to hold ourselves accountable when we get there? Because whenever we go and do things, we're doing this, we're doing that, we're doing this, but then we don't look back and say, what were we actually trying to achieve, and what were the measures and numbers we were trying to do? So I just want to flag that like rather than just going forward, let's think about where we're trying to get to and then work backwards from there. In 2024 and 2025, the urgency alarm continued. Senator Bernie Sanders called for a meeting, and when Senator Sanders calls for a meeting, you show up, and a number of us showed up. And then when you show up for a meeting with Senator Sanders and he's not in a good mood, he shares his mood with you and lets you know that you need to take action. And he did this, I guess it was May of 2024. I was at that meeting. And he had some sharp criticisms for everyone in the room, including CEOs of hospitals, including CEOs of, or a CEO of a hospital, a CEO of an insurance company, Department of Health, myself, others. He basically said, what are you all doing? This needs to be solved. Solve it. In Vermont, we often pat ourselves on the back for the smallness and the way we all get along so well, and I love that too. I'm a lifelong Vermonter, and it's one of the great joys of living here. But at the same time, sometimes we actually need to solve the problem rather than all get along really well. And I hate to say it, but when we all get along really well, I'm not sure we're always solving the problem. Sometimes that's the path, but we've been getting along really well for a while and we haven't solved the problem. So if we need to do something different, let's do it, because this is not going to work much longer. In 2025, I called a series of meetings. We were looking at insurance rate increases of 20%, highest premiums in the country, and it looked like we're going to have another 20% increase on the highest insurance rates in the country. And I didn't want to approve the highest rates in the country again. I just couldn't do it. There's a real problem with it too. It's not just it's not fair and it's bad, but beyond that, it's horrible for the sustainability of a system. As you increase the prices, people stop buying. If people stop buying, there's fewer people with those high-paying commercial plans when they go to the hospital. That means you have more people going to a hospital that are bad debt or free care, or they're paying out of their life savings. So you actually need to make sure you keep up the volume of the insured people. So you can't just add more money or you're going to lose them, and that's really, really detrimental to hospitals being able to remain solvent. And we're starting to see some of that, I think, right now in some of the data we're getting, It's looking more and more like there's some drop in utilization, and that's usually correlated with people dropping insurance because it's too expensive. So that will cause further pressure on hospital finances, which is really, really concerning. So as a regulator, we have these authorities, we have these powers, and it is our job to use them appropriately, yet judiciously. And I would much rather do the get-along thing where everyone can solve the problem together, and that's why I called this series of meetings in May of 2025. It's not great for the system when the regulator has to make the calls and do it itself. It's better if the system works together in that nice Vermont way and comes up with solutions. So I called this series of meetings with a whole host of people and said, I need $400 million out of the system immediately. It's either 200 or 400. We have to reduce spending by $200 to $400 million in a number of months, or we're going to have a 20% insurance increase. Please, everyone, work together and find a path for this. And unfortunately, that process that I initiated, while there were good meetings and good conversations, saved $0.00. There was not one nickel of savings that was brought to the fore. So that created a problem where then we got the rates and we had to do it. And that is not where we want to be. I will say we were able to do it, though. We were able to drive down the rates. Vermont actually had the second lowest rates in the country last year. And it was a little bit of a one-time trick, is what I'll say. Not trick, but it's a one-time event. I'll get into what we did and what the legislature did, but it's not something that's sustainable, and it's not something that's good for the system. We had to do it, but it's not going to be something we can do every single year. So just real briefly, I will focus on how much our insurance costs, because it's very, very important to having a good health system that it's affordable. But between 2018 and 2025, premiums for the average lowest cost plan in Vermont grew 169%. And the annual compound growth rate in Vermont was 10 to 15%. And nationally, it was basically flat. So you can see in 2018, Vermont is the one that goes up a lot, and the rest of the country is the flat one. But in 2018, we weren't that far off from the rest of the country. We were like right kind of in the ballpark. And then we just grew through the sky as everyone else stayed low. And one thing, in healthcare and in the State House, people often will say, well, that's because of this or it's because of this. But we can say what it's because of, but unless you're going to do something about the because of, it doesn't really matter. So when I show this graph, people, well, we're old. That's why. It's like, well, all right, well, you got a solution to get young real quick? Because I've been looking as I age, and I haven't found one yet. But the other thing is, there are other old states. New Hampshire is actually, I think New Hampshire is actually older than us. Maine is almost as old. Rhode Island's almost as old. Connecticut is old. And they're not going up anywhere like us at all, like not even close. So we have to arrest this. We've got to shallow this out at a minimum. We've got to start leveling it back towards national, or people will drop insurance. And that's bad for public health. It's bad for those families, and it's bad for the health hospitals and everyone else's sustainability. There's a number of things that are driving this. I always get asked why. One is a lot of people have left this market. Keep in mind I said there's about 70,000 people. A lot of people, the healthy people, are going to different options because their health costs less money. So if you're healthy, you can get insurance for less money. And this market doesn't give you that advantage. So you go to buy other insurance products and you leave this. So this actually leaves our sickest and most vulnerable in the pool. And when it's a sick pool of people, it costs more money. But it's really, really bad for the system for a number of reasons. These are individuals. Do you know what individuals get health insurance? It's your carpenters, it's your restaurant workers, it's people who have it's your farmers, it's whoever can't get insurance through their work. The small group plans are often dairy farms, there'll be restaurants, there'll be mental health providers, there'll be all these. Those are really, really important to your economy, and you want to keep those people here because there's an adverse thing that happens. For some carpenters and people who are laborers, it's actually better for them to not make enough money to have to go and buy insurance. It's better for them to work less and get Medicaid. Have you tried to hire a carpenter or a plumber or electrician here in this state? It's very, very, very hard. And my brother's a carpenter. It's very difficult to get a carpenter in this state. And also it's just not right. Like, they need to have health insurance, and they shouldn't have to pay $30,000, $40,000 a year to do it. Yeah, and here are the actual numbers of what it costs. There's a note on here before subsidy. There were subsidies that were called enhanced subsidies that went away this year. The federal government, that was what caused the shutdown this last year. I don't know, it's really long. It's the longest one in history. But that was a fight over these subsidies. The Democrats were arguing these subsidies should exist in this market to make healthcare less expensive. The Republican Party was trying to get rid of them, and ultimately they were terminated. So in any event, if you look here, the Platinum Plan for a family of 4 on Blue Cross is $4,400 a month. So, $45,000 a year for your premium. Keep in mind, you also have copays, right? And you have a deductible and a max. So anyway, it's a ton of money. I don't know how many families can really afford $45,000 for health insurance. There's not many. Even if you go to like a gold plan for a family of 4, it's $3,700 a month. So again, over $40,000 a year for a family to buy health insurance. That's just a ton of money. Okay, so I want to talk about some bright spots. There are some, and I think we need to keep some momentum going on some of these efforts. But the first one, so here this is just a headline from last year, is we had a 20% rate increase request in front of us. That's just one. There's 4 plans, but one was over 20%. And Vermont healthcare regulator approves lowest insurance premium increases since 2022. The Green Mountain Care Board significantly reduced initial request by Blue Cross of Vermont and MVP for much larger increases. So that was what I was talking about. We just had to do it. We just could not let it go that high. And again, here's the national. Vermont was the 50th lowest in the country out of 51 if you include DC. The average increase in Vermont was 2% last year. The US average increase was 26%. So we beat national by a lot. And keep in mind, I'm just talking about the plans that we do, that's 70,000 lives, not all the others that I don't have in front of us. So how did we do it? Because when we do that, there's less money to everyone who provides health care. That's the whole rub here. The first thing that happened was there was a cap on drug prices Vermont hospitals could charge. When you go to the doctor for an outpatient hospital-administered drug, those are drugs like chemotherapy drugs are probably the best example. The hospital charges they have a profit on those. They upmark the charges, and then your insurance company pays that, and then the insurance company charges you more because they're paying more to the hospital for it. Last year, around a little before this time, we were reading a report, and it turned out we found some data that Vermont actually had the highest outpatient drug prices in the country. So there's something called average sales price. That's like the average price that somebody pays for these drugs. Vermont was over 600% of the average sales price. If the average sales price is 100, we were 600%. National average was more like 240, and the lowest in the country was like, I think, around 140-ish, if I remember correctly. And what that means is if you're a patient, an oncology patient, you're paying 20% of that 600% markup. That's a big, big, big markup. 20% of 600% markup is a lot more than 20% of 240% markup. Now, our hospitals were making a ton of money on these things, just a ton. And to be fair to them, they would say, we need it. These are our expenses. We have to make the money where we can to survive. If you take this away, we're going to have a hard time providing all the care and access that everyone needs and wants. At the end of the day, the legislature ended up passing a law that capped those prices at 120% of the sales price. That means hospitals could get a 20% markup, not a 600% markup. That saved, I have a slide here, I think it was around $100 million on the for insurance. Insurance would now pay $100 million less. So when I say insurance, I actually really mean the people who buy insurance, not the insurance companies, because our insurance company was nearly broke. So Governor Scott signed that into law, and it was very, very, very impactful in terms of us getting our rates down to a more appropriate level. The other thing we did was the state regulator, that's the Care Board, we cut $88 million from the University of Vermont Medical Center's budget. Why did we do that? Well, a couple of reasons. UVM at the time had a very, very large amount of reserves in the bank. So they had a big bank account, essentially. And we felt that it would be appropriate, given that they have a lot of the healthcare dollars in a bank account. There's something we look at called days cash on hand. We look at a whole host of things for how healthy a hospital is financially. And we essentially said, we will be better off as a system if we use that $88 million to have lower insurance premiums than we will if UVM has another $88 million in the bank account. I think at the time UVM had $1.3 billion, maybe 1.4. It was in a position, it's a big system, like it needs a lot of money, there's no question. But we determined that $88 million would be better spent lowering rates for people, because if they kept going up, it would be problematic. The other thing we found on that was UVM had been using a lot of money from the medical center to pay expenses at its New York hospitals. It owns 3 hospitals in New York, and those hospitals were, 2 of them were losing a lot of money. So they took loans from the medical center to pay the expenses in the New York hospitals. And I really didn't think that was appropriate, because the money in the bank really came from Vermonters paying high prices. And so we said, okay, if you're gonna, I think it's over $100 million if my memory's correct. We said, if you're gonna loan out $100 million to New York, we value those New York hospitals. We want them to exist. We believe in this system here. But the right solution for their financial problems is not us paying more to loan those hospitals money, because Vermonters don't go there that much. The right solution would be for New York Medicaid to pay more appropriately, or for those larger commercial insurance companies in New York, charge them the more money, not Vermont. So we prohibited a transfer of money, or actually we lowered their rates so they couldn't transfer the money. After that, there was a whole, I want to give UVM credit. They looked hard at what they were doing and how they're operating. And we had a settlement with UVM, essentially. We negotiated something with some of their leaders. And we came to a position where they have an outside liaison. There's this gentleman named Mike Smith. I never want Mike Smith looking over my shoulder. and sometimes he does. But he was the Agency of Human Services Secretary. He was the Agency of Administration Secretary under Douglas, and then he was hired by Governor Scott. And he's a very effective person. He's a person of high integrity, and he really cares about Vermont. And he will do what's necessary. He's kind of known as Vermont's fixer. And so I called him and said, I'd like you to help at UVM. Let's do a longer term picture of what we need to do to get this affordable, because their prices were high. So he and a team have been working with the UVM team for maybe about a year now or so. And they're working on a longer term vision to how to drive down prices while keeping everything very high quality and accessible and financially solvent. I mean, UVM is the most important provider we have in the state of Vermont. Many people in my family have received care there. We've been born there, we've died there, and everything in between. So that saga, I'm happy to say, where we kind of had to, is in the press a lot. There's a lot of press about us going back and forth with UVM. They changed some of their leadership. I get along really, really well with their leadership. I am very bullish on where they're going, and I'm really pleased with where things stand. So I think that that's good for this community. I think it's good for the state of Vermont. So these are the numbers that effectively we took out of the system to drive down those insurance premiums. So that drug price cap saved $104 million. The Green Mountain Care Board's hospital budget orders took out $94 million. And then enforcement on hospital budget overages was another $31 million. So we took out $230 million. And that got us to about that level where I told the leaders back in early May, we need to get to this level. So fortunately, we were able to do it. And it really didn't actually have that much disruption on the system, which is kind of the sweet spot for us. It's very, very hard to take away money and not have disruption elsewhere. There's a cause and effect. But we were pretty strategic on where we took it and how we took it to make it all work, and it did. But my point here is we can't do that every single year. I don't think we can go to UVM and say, okay, can we have another $100 million out of your bank account? And what about next year? You got another $100 million, maybe $300, we just can't, that doesn't work. And the other hospitals don't ultimately have the reserves or the profits off the other lines of care to do it either. So to me, this was something that we were able to do for a year. Maybe we can do it again, I don't know. But it's not something that this is not a strategy that's winning for long term. It's kind of like the education tax, the property tax buy down. So essentially the governor the last couple of years has been buying down property taxes with other money. That's kind of what we did, and that only works for so long. So the fundamental problem is that our system is not a good system of health care. And that doesn't mean like the providers aren't good or you can't get good care, but I mean like how the system functions is not a well-functioning system. That letter from Governor Scott led to this report called the Oliver Wyman Report, which was an independent report that we at the Care Board commissioned. And it took a look and said, okay, here's what, give us all the data and numbers. What does it mean? What's this mean for the health system in Vermont? And this is a slide that shows the projected shortfall in dollars in our hospital system alone, not the other parts of the healthcare system, just the hospitals, if nothing changed. So if hospitals had a 3.5% revenue increase and they had a 7 to 8% expense growth, which is what they had been having every single year, by 2028, we would have about a $2.4 to $3.1 billion 5-year shortfall. Translated, what that means is if we don't want to change the hospital system, we need to come up with $2 to $3 billion in 5 years. So keep in mind, extremely high property taxes, highest insurance premiums in the country, broke insurance company. Can anyone in this room, and you can have my job if you have my job anyway, but if anyone in this room can tell me where we can come up with $2 to $3 billion, you can have my job, if the governor agrees. Yeah, there's no way. There's no way possible. So what does that mean if we're $2 billion short? And this actually might have been bullish because this was before H.R. 1. The Trump administration made changes on Medicaid. We've made changes on the subsidies that I talked about. So this actually was pre a number of federal changes that might actually make these numbers seem rosy. The consultant also deemed that our healthcare system is, quote, badly broken. I'll kind of explain what that means. Part of what that means is that we don't have access to the right care at the right place at the right time. And our mantra as a state has been right care, right place, right time for a decade or so, but we don't have it. What we've done is really consolidate a lot of our healthcare in hospitals. Hospitals are critical. You can't go to a primary care doctor. I have a torn labrum. I can't get it fixed at a primary care doctor. I have to go to a hospital. And my spouse had cancer. She had to go to a hospital, right? That's how it works. But you can't go to a hospital for a tick bite. You can't go to a hospital for mental health needs, maybe in some circumstances. But if that's your primary source of care, that is a broken healthcare system. And when I became the chair of the Care Board, I kept hearing that you couldn't get a doctor in this state. And I hadn't had a doctor for 7 or 8 years since I'd been here. I'd never had a primary care doc. It's fortunate that I was healthy, so I just kind of didn't bother. I called once or twice and didn't get one, and I was like, all right, forget it. So one day after work, I started calling every primary care practice I could, trying to get a primary care doctor. I think I called between 6 to 8 places in one night. I did not get a primary care doctor. In fact, the best I got was call back in like March or 6 months from now, and maybe you'll get off the wait list. I don't even think I got on a wait list. So it was true. If you can't get a primary care doctor, your health system is broken. You must be able to get primary care doctors because that's how you detect all these issues before. That's how you treat things very, very quickly and inexpensively. And here in Vermont, that is something, a sore need that we have. Another major problem is long-term care and mental health care. We don't have enough access for long-term care. And as a state that is aging, that is a huge need. And our consultant, I forget the number, but it was many, many, many hundreds, if not thousands of beds that were short for long-term care here as a state. So huge, huge need. And then mental health care and substance abuse, same thing. We just simply don't have the providers. If you look at health outcomes in Vermont, our health outcomes are actually pretty flat on physical health. We're not really improving and we're not really going down, but where we're really seeing bad data is on mental health and substance abuse. We're getting sicker and our mental health is getting worse. So the logical solution to that is to have the right investments in those areas. But if you look at the data, that is not where we're making the investments. We're making the investments on sick care. We're not making the investments on preventative care. And that is what we've got to somehow flip. The other thing is there's a lot of hospitals in Vermont providing a lot of care, and they all have various challenges staffing it. They can't get enough nurses, they can't get enough doctors. In some cases, they don't have enough patients. That is an incredibly expensive setup. So what the consultant, Oliver Wyman, it's actually a firm, not a person, but the firm, Oliver Wyman, recommended was centers of excellence. They said, you're not going to be able to survive like this because you're down $2 billion. So you need, Copley to be an orthopedic specialist center. You need this other place to be mental health providers. You need this to be inpatient psych. You can't all be doing everything. But because of the way the system is, they kind of have to even survive financially, because you make so much money on dermatology or orthopedics and radiology and labs, but you don't make so much money on mental health care or these other things. There's like a disconnect between what we say we value and we need and how we actually have the insurance companies pay, and even how Medicare and others pay. So the long and short of all of this is we need immediate, intentional transformation of our healthcare system. We've got to add the long-term beds. We've got to add the mental health capacity. We've got to add the primary care capacity. That is critical. We've got to reshape some of the hospital system, not close hospitals. The goal is to not close a single hospital. But will we lose services? Yes. We must lose services. We cannot pay for all these services. But the question is which services and how do you manage that? Because if we're not going to lose services, then you're also saying, give me a 20% rate increase, okay? And that's, when I go into different rooms, I just can't, it's very difficult to hear, give me 0% rate increase, but don't change a single thing. It doesn't work. So what we want is intentional transformation, and that's actually a really bright opportunity we have here in the state right now. We've been at this for 4 years since the governor sent that letter and signed that bill. So we've done the work to acknowledge where we are. We've seen what happens when we don't, and we just got $200 million a year from the federal government to do transformation. The governor and AHS submitted an application for a program called the Rural Health Transformation Fund, and that's a fund of $50 billion for the country, and Vermont got $1 billion. We did extremely well for the size of our state, and that $1 billion is given to us over the next 5 years to do exactly this. So we're sort of at the precipice of actually doing the work that we need to do, although it's hard. And why I think it's critical that we have intentional, system-driven transformation is because when we don't, we actually lose the services that we might really want and need. So I said there's a disconnect between how we pay. Well, that disconnect in how we pay and what we say we value actually results in cutting services that we want. So if you have inpatient psych or you have primary care, those don't make margin, they don't make profit. And so what do? If you don't have enough money, you cut those. So now we're having a system where we're actually losing the most important services that we need, and we saw this happen. When UVM had less money, they cut inpatient psych, they cut primary care, they cut dialysis, and I'm missing one. And that was unintentional, unreviewed system change. It was good in their short-term interest, I would argue never necessary, because they had extra money, but that's what happened, and that was not the outcome we wanted as a state. Similarly, Copley Hospital cut its birthing center, so now there's a birthing desert in the Morrisville area. As a system, if we were to look at this and say, hey, what changes do we want to make? These would not be what we picked. That's why we need to have some, and I'm not necessarily a big government person, but this is what happens if you don't have somebody saying, okay, and I don't care who it is, but somebody's got to look at the whole map and system and say, here's how it needs to work, because otherwise people will cut things in their own institutional short-term interests. That's not great. So my comment about not putting the money consistent with our values and our views, a lot of our healthcare reform for a very long time has recognized that we need to have lower spending in hospitals. We need to have more spending in the mental health area, primary care, preventative care, all of that. And the all-payer model, which was innovative, sounds too laudatory to me, to be honest, but it was an effort at a healthcare reform. And the goal of it was to reduce hospital spending and to move money in a way that changed how we provided care. But over that period of time, from 28 to 2022, you'll see the biggest increase in our spending in healthcare in Vermont was actually on hospital care. If you add hospital care, if you add spending in hospitals, that means you're not doing preventative care well, you're not doing health outcomes well, and you're not doing a good job at getting care in the right place in the right time. Because hospital EDs are not the right place for a lot of care, but that is what we are seeing happen quite a bit. So in 2030, when I come back, I want to see this the other way. I want to see hospital spending go down. or be relatively flat, and I want to see these other ones go up. That is the goal of our healthcare reform. All right, I'm going a little long, so I want to speak about this Medicare cost sharing issue. The Green Mountain Care Board received a public comment. Anyone here can send us a public comment anytime they want. And the public comment said, why am I paying so much money for this care that I just got? And they went to a critical access hospital. So on the left is a critical access hospital and what this senior experienced. They paid $11,000 for, I think it was an outpatient knee replacement. $11,000. If that exact same procedure were performed at a PPS hospital, that's a bigger hospital, that patient would have paid $1,676. Huge amount of money. Keep in mind, our rural seniors make about $48,000 a year in household income. So a $10,000 difference. 20% of their income was unnecessarily spent on this. And again, the reason for that, just to reiterate it, is hospitals have something called a charge master. That is their list price. Medicare doesn't really care what your charge master necessarily says. They say, we're going to pay you this. And at a critical access hospital, the patient pays 20% of whatever you say your charges are at the hospital. It doesn't care what Medicare says. The patients have paid 20% of that list price. At University of Vermont Medical Center or the other large ones, the patient pays 20% of what Medicare pays. So if you charge $1,000 and Medicare says, well, we're only going to pay you $100, the patient pays $20. Same thing at a critical access hospital. They say it's $1,000. Medicare says we pay $100. How much does the patient pay? $200. Okay? Does that make sense? It took me a while too. So there's a list price at a critical access hospital, and there's the amount Medicare pays. You go there, you pay 20% of the list price. List price is $1,000, Medicare pays $100, you pay $200, 20% of the list price of $1,000. UVM in Burlington, list price $1,000, Medicare pays $100, you pay 20% of the actual amount that's paid. That's $20 of the $100, 20%. So it's a huge, huge equity issue to me, where some people, just by being rural, and frankly, I don't think we should be discriminating against our rural seniors. It's not necessarily like intentional discrimination. No one's necessarily a bad person here. It's a function of two things: the federal rule that says this is how it's done, and then second, the charge masters at some of these hospitals being very, very, very high. So we have called a series of meetings to address this issue and asked, the first step, please come and tell us how you're going to solve this, because it's not okay. And the concern that some hospitals have, and this will get a little bit confusing, but when they go to the commercial payers, they get paid off what's a discount off charges. So the commercial insurance companies say, okay, we'll pay you 80% of your charges. So in that $1,000 example, the insurance company would pay $800. So if they lower their charge masters so that the patient's paying the same amount for the Medicare side, that commercial side, now they're only getting 80% of a lower amount. So they don't want to switch that charge master, or they're going to lose potentially all this commercial money. So what do you do? I think we have another hearing scheduled for early May. We already had one hearing on March 24th, calling people in to help talk about this. It's a working group we have set up. You could lower the charges. You can renegotiate with the insurance companies. There's a number of things you can do. So we want to have that explored to solve it. There's a current bill in the legislature called S-190. I made a fair amount of noise about this, and I'm going to continue making noise about it. I don't think it's right. I want it solved. And we will, as a regulator, do what we have to do that we think is in the best interest of the state. Their S-190 was amended after we had this hearing to say that the Green Mountain Care Board is prohibited from using its regulatory authorities to address this problem. So if you disagree with that amendment, I suggest you speak with your legislators and you tell them your thoughts on this, and that maybe they have other views or there's other things I'm missing. But I do not think it's appropriate for the regulator's ability to address this problem for seniors to be cut short before we explore all options and try and address it. That's my personal view. I will be opposing that amendment on S-190. And this just is another example of what I was talking about. I don't want to belabor it too much, but it's important to note that if we actually solve this problem, at least on the Medicare side, what happens is Medicare pays more. You flip it. Instead of the patients paying more, Medicare pays more, the federal government. That is incredibly important because it's an economic driver for people to have more money in their wallets in our rural communities. If you take all of this and sugar it all off, what's happening is Vermonters are paying seniors for this type of care at critical access hospitals are paying 48% of the amount of money that's paid. Under federal rules, that can be 20%. So we're giving up, we're paying 28% more than we have to. And if we pay the 20% rather than the 48%, we keep that money and Medicare pays the other amount. That's the point of this graph here. So if you look here, in the first example, Medicare would pay $32,000 and the patient would pay $8,000, and the critical access hospital gets $41,000. If the hospital increases its charge master, that list price I talked about, Medicare would pay $20,000 and the patient would pay $20,000, and the critical access hospital would still get $41,000. If the critical access hospital charges 5 times the payment, if it's really, really high, the list price, the patient would pay every single nickel and Medicare would pay nothing. Now these are just examples, but we are paying way more than we need to. And if we can keep all of those tens of millions of dollars in our rural seniors' pockets, one, they're wealthier, and that's good for them, and they're more stable in their families and their financial lives. And two, there's more money they can spend in their communities. Not as broke as we are. And then last, if you go down at the bottom, number 5, this is the amount the patient would pay and Medicare would pay at the bigger hospitals. Here, the patient would only pay $1,600. So it's a huge, huge, huge disparity. All right, I'm 3 minutes over, so I'll stop there, and I'm happy to take any questions. Thank you.
Okay, this mic is working. So we can take questions now. There's some over here, some over there. I guess I'll go over here because it's closest.
Thank you very much. Appreciate the talk. What would be the possibility or feasibility of trying to mimic something like the system that's used in Massachusetts, where they created like Massachusetts Healthcare, and they decided at the state level how you could do what you wanted to do, and as opposed to being handed all these formulas that you have to deal with now that seem to be rather arbitrary when you have New York State saying, well, I don't want to pay that, right. I want this amount, no, we have to pay New York's price. Why don't we have something that's strictly in Vermont like that?
I'm not sure exactly what are you talking about Mass Health, the Medicaid program? Oh, yeah. So,
yeah, it's called wrong.
Yeah, right. I have not studied it. It has not been an issue that's been brought forth to the legislature since I've been here, but the feasibility of it would have to be something that's brought to the legislature and they would review and approve. I don't, sitting here now, have any sort of huge, like, hey, we couldn't possibly do it, but not an issue I've studied.
Accounts for about 40% of Vermont hospital admissions. What regulatory authority does the Green Mountain Care Board have over Dartmouth?
Yeah, so the Green Mountain Care Board has no authority over the Dartmouth Medical Center. They have a couple other hospitals here in Vermont that we have regulatory authority over, and we do look at their financial health and their parent company's financial health, which is Dartmouth and New Hampshire, but we do not regulate hospitals that are not here. Dartmouth Health, generally, if you look at the data, though, is compared to some of our larger hospitals, is actually quite a bit more affordable. Their prices are lower, and it's not actually bad for our affordability that some patients go there. That's not to argue that patients should, but we need to be competitive with their prices.
Right now. All right. Thanks so much. It's really wonderful to hear from a state official who's so candid and transparent about what's going on. I'm 28, and it's really aggravating because it feels like the social contract of this state has been broken on so many levels, whether that's state funding, whether this is healthcare funding or criminal justice. I have a twin who was an emergency room nurse at Fletcher Allen, and she had to leave the emergency room because she was tired of being assaulted by individuals that go there for mental health care. And I would like to know more about the disproportionate funding that is going towards individuals that are clearly afflicted in a really terrible way. But this wasn't a problem 10 years ago, right? I moved here in 2008, and there was no real issues with the state of Vermont's healthcare system. It was sterling, and now it's horrific. And I'm just really frustrated. And I'd really like to know what is this a crisis of corporate greed, or is this more issues of incompetent legislators?
Are there any other options? I'm not going to pick either of those. But the point is a serious one, and it is, we do have, as I said earlier, if you look at the data on health outcomes in Vermont, mental health is an area where we're really struggling. I don't think it's corporate greed or incompetence. What I would say is it's a more systemic failure of not supporting where we need to support. And yes, as we see mental health crisis go up in Vermont, we do need to have the appropriate resources to address it. It is really tough. That's a story we hear all the time, and it's true. The mental fatigue and the physical risk to many of our healthcare providers, because a lot of people are coming to the ED in crisis, is really, really tough. They're not always safe. And it's not fair to the patient, number one. And number two, it's not fair to the providers. So we do need to have better investment and do a much better job on the mental health side. And that takes resources. So part of, like when in our decisions, remove money from a hospital system, part of it is so that there's money freed up for those other things. If we, in our regulatory duty, give all the money here, there's not much money to go to these other pockets. And so I do think that we need to address it. It's a crisis here, and it needs addressing.
Could you speak to reference-based pricing and how that might play into future hospital budgets?
Yeah, great question. So the question was, can I speak to reference-based pricing and how it will play into future hospital budgets? What reference-based pricing is it's a mechanism by which we look at how much money insurance companies are paying in prices. So keep in mind, Medicare is generally considered the benchmark. Medicare has a whole huge swath of teams of people that determine what it should cost to give care. And they try to pay around 100%, maybe 98%, maybe 101% of what it costs to deliver care. They make that determination. If you're going to give a knee replacement, you need this much money to pay the docs and everything else. But Medicaid often pays quite a bit less. They might pay 55, 58% of what it costs to give care. So what happens is you make it up on insurance, on the commercial people. On top of that, if you're going to have inefficiency or you're going to have a huge marketing department or whatever it might be, that also adds to costs that you would then need to make up on commercial. So what reference-based pricing does is say, okay, if Medicare is 100, what level of commercial payment are we willing to accept? So the national average is probably 250, 260% of Medicare, okay? Vermont, at our larger hospitals, is way higher, like a lot higher. And so what reference-based pricing is we at the care board will set, here's where we're trying to get. We're trying to get the national average of 250. X hospital, you're at 350. You need to come down 100%. And over a period of time, because you don't want to be disruptive, we're going to lower their commercial prices until they get there. That's what it is. The challenge for that will be that our hospital system is in financial strain in many, many places. Dr. Leffler at UVM provided testimony earlier this week. We reduced their prices, I think 8% last year, getting them down, they're high priced, getting them down lower, but the reaction to that, the consequence of that was they are losing a lot of money. So this is a plan. We're going to reduce the hospital spending, we're going to reduce that growth, but it has to be over the right period of time where they can adjust and the system can evolve.
So the system that you've been describing sounds to my cynical view, kind of like a shell game, where shortfalls in various services get pushed around until more often than not they end up in the hands or the pocketbooks of insurance ratepayers. Because you said it's commercial insurance that makes up most of the shortfalls in other
Correct.
services.
Yeah.
It strikes me, nightly as a very dysfunctional way of doing business. Is there any possibility that that's going to ever change or change in the near to a medium term?
Yeah, great question. I personally, I do think it's a bit of a shell game and a kind of a house of cards. And that's the problem. As we correct some of these outlier issues, the system falls apart or could fall apart. So that issue with really high drug prices, to me, that's not appropriate and not sustainable. As we correct it, there's financial pain on the hospital system. This issue of the Medicare copayments, the cost sharing, that's not appropriate either. But if we correct it, there's this other big risk. So that's why I think it's like a little bit of a house of cards, where if we actually correct some of these fundamental problems, we have got to do the transformation that's needed, because we can't sustain this. See Oliver Wyman report that said we're short $2 billion. Your question was, what do we do about it? And I think that we actually have a problem with doing hard things in the state sometimes. I'm getting a lot of laughs. Well, so here's the reality. Is it better to, it's essentially a tax to have really high insurance rates. It's a tax on people with insurance. And I think there had been this notion, well, they're insurance companies and they make a bunch of money and that's okay. And that's true. Like, I think that there are some insurance companies that are, making a lot of money and paying dividends and whatever. But our predominant insurer is not that insurer. It's a nonprofit that's local that is really not in a great financial position. So what do? They ask us for more money. Is it good to tax people through a high commercial rate, or is it better to actually tax people? Because we're going to need more money, and it's just a question of, do we pay for it this way or this way? And I would argue, this won't be very popular, but that we should actually pay for it through taxes, because at least then you're spreading it across everybody, and people are paying more of their fair share, rather than our carpenters and plumbers and farmers and restaurant workers paying an exorbitant amount. I think that's bad policy. So I would argue we should actually increase the amount we pay in Medicaid and decrease the amount we pay in commercial insurance. Now, if you can find politicians that want to do that, that's a harder thing, because that's a hard thing to sell. I'm not a politician, so I get to say it.
We've got one more question over here.
I can repeat
Okay.
it.
Cost, quality, and access are often in tension in healthcare. Examples include Copley closing its birthing center, Rutland attempting to discontinue pediatric care, and the medical center discontinuing its kidney transplant program and attempting to limit dialysis services in response to the Green Mountain Care Board revenue cap. How does the Green Mountain Care Board balance issues of cost, quality, and access in its decision-making process?
Yeah, okay, so the question was, how does the Green Mountain Care Board consider cost, quality, and access in its decision-making? Those are really the three key factors we look at. And it's pretty complex, but one of them is we look at provider productivity. How many patients are doctors seeing? How efficient is the hospital working? We look at administrative costs. How much money are they spending on administrative costs? And one of the good efforts that Dr. Leffler and the Mike Smith team and the others are doing now is looking at how much money are we spending on administrative costs. There are direct patient care costs, and that's what we want to prioritize. All the other stuff, because we're kind of in a tough spot, we kind of have to batten down the hatches and focus on patient care. So we think that when we make budget decisions, if you ever are bored and read a 50-page budget order, you'll see that a lot of the focus is on where are they spending the money that we can reduce without hurting patient access. And how can you get more efficient, i.e. doctors seeing more patients, because when doctors see a low volume of patients, it takes more doctors to see the patients. In Vermont, we've seen across the system really, really low provider productivity. A lot of the providers are seeing docs in the 20th percentile, 25th percentile of national. We need to get that up so we don't have to rely on so many locums and traveling doctors and nurses. So we got to get that up. And that's a focus that a couple places are working on. Quality, Quality is an interesting one. We've seen quality decline really sharply across the state of Vermont in hospital systems. It's been going down. CMS has a thing called STARS reports. There's other data. CMS gives fines for low quality. We've seen the quality really deteriorating. That is often correlated to traveling nurses and traveling doctors as well. It's not the only issue, but as you have travelers, you do see a correlation with quality declining. So that's another thing that we've been pushing on.
I think we're going to wrap it up there. Thank you very much, Owen Foster, for coming to speak with us, your expertise.